Calgary especially, we know that the systems that we work on try to develop often have potentially unintended consequences or harms when used, right? And I think it's fair to say that those who, are designing, researching, and developing these systems who have some role to play in kind of reducing or mitigating the impacts of these harms. But of course, identifying these harms, all the potential harms from algorithmic systems, it's hard to do just like one person, right? Because one person only really has their own sort of background and expertise. For example, many of us in this room, fairness issues are probably at top of mind. But for others, we could be considering issues related to social groups, the economy, privacy, the environment, lots of different things, right? And since algorithmic systems have such a broad potential scope of impacts and potential harms, a couple of things that I think are important is to have this diverse team that comes from these different sort of domains so they can contextualize the impacts within their own realm of expertise, and also having like a framework to kind of bring these things together in a systematic way that allows them to kind of comprehensively identify all these different impacts. So a framework like this was presented last year at the AI Ethics and Society Conference by Shelby et al. And in this sociotechnical harm taxonomy, they discuss these different harm categories in the context of algorithmic systems, and particularly how systems can kind of lead to harm through the entrenchment of existing societal inequities. And in this paper, they discuss these harms a lot in the context of systems like social media, LLMs, a lot of these applications that are kind of direct user facing, right? Because in a lot of these situations, the person experiencing the impacts will be the one directly interfacing with the AI model. But in our case, I think it's a little bit unique because, the systems that we kind of work to develop here in Mackay, we kind of designed them with, for the most part, with like a clinician intermediary in mind, right? So in these situations, I think there's a little bit of a unique relationship between how AI kind of interacts with society and how the potential harms that could, result from this sort of unique relationship. So in our paper, we kind of use this sociotechnical harm taxonomy that was proposed from this conference to kind of as a foundation for systematically identifying various different ways that AI can lead to potential harms, specifically in the medical imaging context. So I'll go through kind of briefly each of these harm categories and just have a quick example from each one. So starting with representational harms, the reinforcement of unjust societal hierarchy of the algorithmic systems. And I think this category is particularly relevant when you consider the data that we as researchers rely on to both develop models and perform our spectrum fairness analyses, right? Now, as anyone who's done this kind of work, I'm sure is familiar with this sort of metadata where oftentimes we are kind of stuck with these very underrepresented groups that just kind of have to be grouped with this other category, to get significance and whatnot. And when we do this kind of analysis on these groups, like we don't know, why is the model performing well or not on this other group. We don't really have any idea of the impacts of the model on those underrepresented groups. And further along that spectrum, we can also have groups that experience sort of like algorithmic erasure, right? Where we have some groups that are not represented in data sets at all. So populations that may be marginalized from Western healthcare systems, or maybe people who don't even like identify with any of the predefined categories on data collection forms, right? So I think in general, the kind of data that we use, and that, obviously we're kind of stuck with in a way, it can still kind of negatively impact these already marginalized populations when these models are kind of built and implemented. Second one is allocated harm. So this has to do with the uneven distribution of algorithmic decisions between populations. You might be familiar with these terms of opportunity economic loss. And if we consider maybe an AI tool that is trained to detect lesions or something, for medical images, and we know that models are destined to make mistakes sometimes, right? But we could have a situation where this clinician who is using this model, maybe they kind of become over reliant on this system. Maybe they're having a little bit of automation bias, and maybe because of that, they end up, trusting the model and missing maybe early disease indicators that maybe then progress into more severe conditions, and maybe that leads to missed healthcare treatments or more expensive medications or hospital payments, right? And that's not to say that diagnostic errors don't occur now without the use of AI, but as we know, these systems often do have these performance disparities on these already vulnerable populations, which could then kind of be compounded in a way. The quality of service harms, these are due to the systematic algorithm performance disparities between populations. An example under this, we could consider maybe a clinician is being told to use a computer-aided diagnosis model by their health authority or whatnot, and they're told that, yeah, this model is really great. We're great for group A, but a little bit biased. Group B doesn't have as good performance. So in this case, we can kind of consider like a harm sort of on the clinician, right? Because maybe this user of the AI system who is responsible for making decisions with it can kind of experience this increased labor, maybe like have a higher mental burden or load. You may worry about the mistakes the AI is making. Are they going to be liable for it? Are they questioning their own judgment if maybe it disagrees with what the AI model is? Your interpersonal harms, these are due to the negative influence of economic systems between individuals or communities. And an example under this sort of category is maybe you consider a clinician using a computer-aided diagnosis model, maybe for treatment advice, and maybe they make maybe the clinician's decision kind of aligns with what the AI is saying. But potentially we could have the scenario where a patient, maybe they don't really agree that that treatment is appropriate for them. Maybe they have sort of lived experience that they want to share with the clinicians that maybe they want to not kind of go through with this treatment, for example. But the clinician is already kind of in this position of power and authority over the patient, right? And expertise. And maybe they then point to the AI model and say, well, this AI model is actually an expert. It's supposed to be objective. So we're just going to go with what this model is saying. So in this way, this sort of algorithmic paternalism can kind of introduces loss of agency on the patient who is maybe not experiencing kind of being heard in their lived experiences. And of course, this has potential to kind of disproportionately affect people who already experience this dismissal of health concerns, often due to gender or race or things. Social system harms are kind of more of a macro level effects of algorithmic inequity. And this is the example here, kind of very in line with the themes of the conferences here. We know a lot of the models that we kind of work to develop, a lot of times they're using, MRI or expensive, similarly expensive imaging modalities. And we know that these imaging systems are not available to everyone, right? So in the case where, maybe we have this really great model used for early detection of Alzheimer's, dementia, or something. But in low resource settings or in places where only wealthy people can access these systems, we're then ending up with this potential for kind of these two-tiered system, right? Like a reduced standard of care for people who are not able to access these systems. So that's a brief overview of taxonomy and a couple of ways that our work can kind of fit into that. In the original paper by Shelby et al., they proposed this taxonomy as a way to kind of get people thinking about these impacts, and also because when we identify these harms, and we can then kind of think about the safeguards and ways to mitigate these harms, right? I think this is interesting to think about in the context of medical imaging AI, because we kind of think of these, maybe performing these impact assessments on these medical algorithmic systems as a way to kind of operationalize the medical ethics principle of do no harm. So to kind of demonstrate that, following these principles, we kind of perform this collaborative group impact assessment for this hypothetical computer-aided diagnosis model for diagnosing Parkinson's disease. We perform this in a group of just 8 people, so 4 grad students, research associate, and 3 faculty members, kind of all in different subdomains under the umbrella of AI and critical imaging. And we kind of went through this process to kind of identify avenues that the lessons can be operationalized in this scenario. So just a brief overview of this like hypothetical case study based on this Parkinson's disease diagnosis model, and we assume that they were going to have this model implemented for AI diagnosis in Calgary, where we're from. This model was trained on data from different countries, different scanners. There's an imbalanced representation of males and females, kind of prevalence of Parkinson's disease, the data sets we have access to. And we assume that there was this subgroup analysis performance, the self-performance varied between male and female. So what we did in this group, we kind of went through the case study and we identified kind of who would be affected by this AI system, what would the potential harms be, considering this sociotechnical harm taxonomy that we've been talking about. And then, identifying potential actions that could be taken based on those identified harms and try and mitigate them. So just a couple of points, major points that came up. One of them was that the result of sampling bias, and like this one that goes on subgroup analysis, this is kind of very in line with things we're talking about in EPIMI. So potentially seeing systematic misdiagnosis of groups based on this sort of sampling bias from these different countries, from these different scanners, and the fact that kind of only male and female performance disparities were analyzed in this hypothetical model, which could then lead to kind of these particularly allocated and quality of service harms. And similarly, it came up that we actually didn't know how the system would perform on prodromal or early stage Parkinson's disease, because we didn't have any information on, if these maybe early stage borderline cases would be were represented in the data set. So similarly, that could lead to kind of maybe this misdiagnosis rates within this subset that could fall under these allocated quality of service harms. Something interesting that came up is that in Calgary, actually, there's a pretty long wait time for MRI, even though it's publicly funded, you have to wait quite a while to receive a scan. So this kind of brings up an interesting scenario where maybe if a patient has already seen a neurologist, in a standard workflow, maybe they would already be diagnosed, but with the AI system, maybe they're told, yeah, you actually have to wait to get your MRI scan before we can do an official diagnosis. That kind of leads to this almost like net loss as a result of using AI, right? Because then maybe they're missing treatments or other sort of supports that could have helped them throughout that prolonged diagnostic process. And finally, it also came up that neurologists don't really think about, like, they don't currently incorporate AI into their workflow, so it could potentially also have a kind of impact on how the neurologists will diagnose Parkinson's disease, and could potentially lead to issues with increased labor on their part, and maybe things like underutilization or inappropriate use of AI within their context of their workflow. And then after we went through kind of this list of harms that we identified, we kind of found that two sort of main mitigation measures could be taken. One of them would be performance out or transitional trials throughout this process, which is when the AI systems are kind of used and analyzed in the context of workflows, but without actually affecting the standard of care, right? So with the research team performing these kinds of trials, they'd be able to kind of identify whether there were previously unknown demographic or scanner acquisition biases that are affecting the particular population that's being applied on. And it would also allow us to understand, like, how does this actually fit into the clinical workflow, through discussions with neurologists without actually just giving it to them and saying you have to use it now. Another kind of concern that was coming up in our discussion was privacy. So something that could address privacy concerns, we thought about doing public outreach and education, actually just making sure that we're informing patients and their families properly about how the data is being used. Additionally, doing this sort of public outreach could also kind of identify if there are additional social groups that could receive additional social symptoms like transportation to clinics, for example, in order to actually receive this care and so I'll give just a brief, very kind of high-level overview of what a potential impact of software could look like. But what I thought was really interesting with this activity was that it really encouraged each participant to think of these kind of outside the box risks, I guess. So ones that aren't directly tied to an AI performance queries necessarily. And actually having discussion even across these different areas of this like sub domains of expertise of AI and medical imaging, we kind of discovered that we were able to develop this comprehensive list of a lot of different impacts that were affecting various groups. But we did identify that there are a lot of things that obviously we don't have expertise on. So the goal for this type of thing would be to actually truly have interdisciplinary discussion, right? So discussion across, from our perspectives as well as, ethical, ethicists, legal, policymakers, and we do have the full summary of this sort of activity on the paper if you're interested. But yeah, just to wrap up, typically when we talk about the negative impacts of AI on medical imaging, we're often talking about privacy, and of course now talking about fairness more, which is great. But I think this sociotechnical harm taxonomy, which I highly recommend reading, if you haven't, I think it has a very interesting framework for actually thinking of these more outside the box impacts that AI can have. And doing this sort of impact assessment can kind of be one component, I think, of this sort of multidimensional framework to be able to develop and implement AI in medical imaging and healthcare ethically and responsibly. So thank you for everyone who supported it. That's a good point. I think in our kind of discussion, we did end up focusing mostly on assuming that this model would then be different practically. What could we do if we're maybe given this scenario? But I think that's a really good point in that I think these processes where we're thinking about, how to responsibly and appropriately implement AI systems in medical practice. I think it does have a big sort of iterative aspect, right? Where in the context of, I guess, silent trials, for example, like we're seeing, how these systems interact. Like if there are biases, then okay, then we can all go back and kind of see what we can do to mitigate those effects or impact on the population. So I do think that sort of iterative process of developing and then seeing the impact and going back and fixing those mistakes, I think is really important part.
I also have a sort of quick question. A lot of this work seems to be about taking harms that may be either underrepresented and bringing them to the surface, or possibly potentially invisible and also bringing them to the surface. What do you think of the importance of necessarily diversifying not only the different types of people we collaborate in terms of ethicists, clinicians, et cetera, but also the diversity of their background?
Yeah, I think that's a really good point too. I think even in our small discussion within our group, we do have a lot of diversity, not just like in domain expertise, but also in terms of where we're from, our actual backgrounds. And I think that actually plays a big role in it because growing up in different scenarios and environments, you do you're exposed to things that give you different perspectives, and I think that is a huge thing that we need to consider too, like this sort of global sort of collaboration and getting perspective, not only from different expertise, academic expertise, but from different lived experiences as well.
Thank you.